Hello, you're welcome to my channel. I am Dr. Sandra. I am a medical doctor and a surgeon. Those that are new to this channel, you're welcome to my channel. I make videos and post on this platform to create awareness and sensitize the general population and my patients about the different surgical conditions so that we can have a very good surgical outcome in our patients. Those that have been with me from the beginning, you're welcome back to my channel. And thank you so much for the support that you showed me in my first video. Thank you for commenting. Thank you for liking. Thank you for subscribing. And I urge you to continue subscribing, sharing, commenting on my videos. I am back and I want to continue the conversation from where we left off. We talked about wounds in the first video, and I want to continue this conversation to talk about the tissue that replaces your wound, the scar. In this video, I'm going to talk about the different stages your wound undergoes, and also talk about how you as a patient can enhance these stages of wound healing, and also talk about the abnormal scars, the keloids, and then the hypertrophic scars. I'm also going to talk about the things that we as patients can do to make sure that we don't end up with the keloids and then the hypertrophic scars. So let's start with the stages of wound healing and what you as a patient can do to make sure that you support and enhance these stages of wound healing. So, when you get injuries, when you get a wound, the first thing that happens is your body tries to make sure that you don't lose blood. And the first thing that happens is what we call vascular response. During the hemostatic stage, the first stage is vascular response. And vascular response means that there are some changes that happen in your blood vessels to make sure that you don't continue to lose blood. The first thing that happens is you get what we call vasoconstriction. Vasoconstriction means that the caliber or the diameter of your blood vessel reduces and becomes smaller. And that way the volume of blood that is lost within that blood vessel is actually also reduced. The other thing that can happen is vasospasms. Vasospasms meaning the walls of the blood vessel tend to contract, and when they contract, the blood loss is also reduced. The amount of blood, the volume of blood that is lost is also reduced. The other thing that can happen is formation of a clot, and this happens through recruitment of the platelets into your wound and activation of the coagulation cascade or activation of the clotting factors, so that at the end of the day, the overall picture in your wound is formation of a fibrin mesh that seals off the blood vessels that were trying to bleed. However, in some instances, the bleeders are big, and the pressure coming out of those bleeders is very high, especially if the blood vessels are big. So what now that calls for is your intervention and our intervention with the surgeons. There's something that you as a patient can do in that instance to make sure that actually hemostasis is achieved, or the first stage of hemostasis is accomplished. For example, let me give an example. You have had a crash injury of the hand. Maybe you were in a given factory working with a machine, and then the machine crushed your hand. There's something you can do. What you can do is toniquating. You can toniquate. You can get a belt, a rope, a cloth, and then tie above the injury so that you obliterate the blood vessels, you close off the blood vessels so that the blood loss is also minimized. The other thing that you can do is get a cloth, any cloth, because at this point we understand you don't have sterile dressings, you don't have you're not working with a lot at this moment. You can just get any cloth and apply pressure, because at this moment we're just doing damage control, not losing a lot of blood. So you can do that. And the moment you tonic apply pressure, please come to the hospital. For those that are patients that are unconscious, they can only rely on good Samaritans, the bystanders at the accident scene. So those people can easily bring the patients to the hospital so that we can continue with the management. We can do electrocauterization where we coagulate the blood vessels. We can also do vascular repairs with sutures. We can also ligate the blood vessels. We can as well also continue applying pressure. So you realize that there is something that you can do to make sure that this stage of wound healing is supported. Because remember, also blood loss affects wound healing. Of course, there is something we can do after that. We can transfuse blood. We can also give IV fluids, but at least let that be done at the accident scene. Okay, so your body now is going to transition to another stage called the stage of inflammation, the inflammatory phase, and that happens around 4 to 6 days. What really happens in this stage of inflammation is there is recruitment of the neutrophils and the macrophages. These are cells of the immune system that are meant to make sure that bacteria within that wound is killed off, the debris and the devitalized tissues are also cleared so that your wound is clean. However, there are some cases when there's a lot of contamination in that wound. Remember, these accidents occur in areas that are dirty areas. On the road, there is dust, there are stones, there is grass. So there is a lot of contamination in that wound. So that calls for you bring the patient to the hospital on time. We recommend bringing the patient within the first 4 hours so that we can do what we call debridement. Debridement entails radical wound excision, where we cut away all the devitalized tissues. We do thorough cleaning with normal saline. We also do thorough cleaning with antiseptic agents so that the wound is clean and so that we can now start healing this wound by what we call secondary intention. After that, we can do secondary closure or flaps. We can use flaps or we can do skin grafting. I want to emphasize this because I have noticed that patients come late, maybe some patients come like after a week, and throughout this time they are using herbs. Not because they don't want to come to the hospitals, because they are unaware of the implications that this delay to come to the hospital will cause. And then they come to the hospital when there's a lot of pus in the wound. When there's a lot of pus and the patient is very sick, he's very septic, because they were unaware of what to do. So I urge you to bring these patients within the first 4 hours so that debridement can be done. Now, within the 7th day to the 6th week, your body is going to transition, your wound is going to transition to another stage of wound healing. And this stage of wound healing is called the proliferative stage of wound healing. And during this stage of wound healing, there is a lot of cell growth. We have multiplication of the endothelial cells to form new blood vessels, multiplication, replication, and reproduction of the fibroblasts to lay down collagen type 1 and 3, but mostly type 3 collagen is laid down. We also have replication of the keratinocytes to make sure that you form new skin, so that you get epithelialization, so that the wounds, they always replicate as they cross over the wound, so that the skin edges align and get apposed. So that is what happens in the proliferative stage of wound healing. There is also something that you as a patient can do to make sure that this stage of wound healing is also supported and enhanced. You can eat a lot of foods that have iron, vitamin C, and protein, because these molecules are very essential for the enzymes that actually lay down this collagen, especially collagen type 3. It is mostly that is predominant in the granulation tissue that is being laid down during this proliferative stage of wound healing. Now, when we transit about the 6th week to 2 years, your wound is going to transition now to another stage called the remodeling stage or the maturation phase. Realize that in the previous stage, we are having replication of the different cell lines, different cell types. But in this stage of wound healing, we are now receding replication. The replication is being withdrawn. So the fibroblasts that were proliferating and replicating rapidly, they tend to dial down the replication. The endothelial cells also tend to stop. They tend to reduce the replication. The fibroblasts, some of them die off even. Same for the endothelial cells, they die off. And some of the fibroblasts actually transition into myofibroblasts. The myofibroblasts are the type of fibroblasts that are actually more flexible, such that your wound is now a little flexible, more flexible than it was before this stage of remodeling set in. At the end of the day, maybe 6 months down the road, 2 years down the road, you have a scar that has no cells, has no blood vessels, and that actually ends the journey of your wound healing. At the end of the day, you're going to, if you don't have any impairment in any of those stages, you're going to end up with a smooth, linear, flat scar, which is called the atrophic scar. It is a normal scar. However, you can have some impairment within, especially the proliferative stage and also the remodeling phase, and then you can end up with a hypertrophic scar or a keloid. I am going to talk about these scars, the hypertrophic scars and then the keloids concurrently, so that we can easily know how to differentiate them. So let's talk about the keloids. The keloids are actually, they have a genetic predisposition, meaning if your mother has a keloid, you're most likely going to end up with a keloid if you get injuries. It is unlikely for you to have, it is actually, there is no genetic predisposition for hypertrophic scars. Meaning, if your mother has a hypertrophic scar, you will not have a hypertrophic scar. There is no genetic relationship in the hypertrophic scars. So there is no genetic linkage. They don't run in families. Unlike the keloids have a genetic linkage. The hypertrophic scars don't have a genetic linkage. The keloids are very common in adolescents and middle-aged people, while the hypertrophic scars are common in children. We feel like that is so because children tend to have tension in their body, in their skin, they are growing, so there is too much tension, and so we tend to have hypertrophic scars in children. That is the science behind it. In the keloids, there is no relationship of degree of injury to the size of the scar. For example, you can have a very slight abrasion, and then that abrasion is going to heal with an overgrowth of tissue. You can have something small like an ear piercing, and then you're going to have a very big keloid. So there is no relationship. Actually, a very small injury can cause a very big growth. You can have a very big keloid out of a very minor, trivial, subtle trauma. It is unlikely for you to have that occurrence in the hypertrophic scars because there is a direct relationship between the degree of injury and the size of the scar. Meaning, if you have a small injury, you will have a small scar. If you have a big injury, you will have a big scar. So that is, there's a direct relationship, which is unlikely in keloids. The keloids tend to overgrow and spill over beyond the point of injury. Meaning, when you get an injury, the overgrowth or the scar is going to be beyond the point of injury, beyond the wound when you form a scar. But in the hypertrophic scars, it will be limited to the point of injury. You will not have an overgrowth. It is most likely because of the collagen synthesis. In the keloids, you tend to have synthesis of type 3 collagen 20 times more than the normal skin, more than the surrounding skin. So if you're depositing collagen 20 times more than the normal skin, it is no wonder you have a big overgrowth, you have a big keloid. Unlike in the hypertrophic scars, where you have six times more than the normal skin. Collagen synthesis type 3 of 6 times more than the normal skin. So for it to just appear elevated above the normal skin, but in the keloids, it will be an overgrowth because it is producing more collagen here in the keloids, and then here less collagen type 3 that is actually being synthesized within the hypertrophic scar. The problem with keloids is even this collagen synthesis that happens in the proliferative stage of wound healing, it tends to even go ahead to happen in the remodeling phase of wound healing. It tends to, the fibroblasts never stop, they go on and on and on to produce type 3 collagen. Even in the remodeling stage where I have told you that they are supposed to be dying off, for them they just continue producing collagen. We have not yet found the reason why they do so, but that is what happens. They just continue producing collagen, even the remodeling stage where they should be dying off and dialing down the production of collagen. They even tend to continue even beyond 6 months. There is no time limit of collagen synthesis. So in the keloids, they tend to grow even past 6 months, but and there's no time limit, by the way. And in the hypertrophic scars, growth is limited to 6 months, and most of the time they are even self-limiting. They tend to stay where they are, the size they are, or even disappear by themselves, which does not happen with the keloids. For them, they just continue throughout life until you do some intervention on them. The keloids are also very common in blacks. Hypertrophic scars have no racial preference. The keloids are also very common in women, but in the hypertrophic scars, it can happen in any gender. By the way, in the hypertrophic scars, you can easily get them if the wound is infected, it has lost a lot of tissue, and it has healed by secondary intention, or maybe it has been sustained perpendicular to the Langer lines, the lines of tension in your body. We always have tension lines. For example, on the abdomen, we have tension lines that are horizontal. When you get an incision, it is not like you will always have a hypertrophic scar, but sometimes you can end up with it if it is actually perpendicular to the Langer lines. For the keloids, they are very poor at responding to treatment, while the hypertrophic scars, they are very good at responding to treatment. In keloids, we tend to have some complications. For example, we can have itching, pain, we can have ulceration, we can have infection, which is unlikely in the hypertrophic scars. The treatment modalities for the keloids, like I've told you, they are very poor at responding to treatment, but when done meticulously, it can actually be eliminated. We can do what we call intralesional keloid excision, or what we call intralesional keloidectomy, where we cut within the mass, within the keloid itself, and then we inject with a steroid after that. We do the steroid injections weekly for 8 weeks. Same for the hypertrophic scars. We can do injections. But in the hypertrophic scars, you can also do excision. You can just excise away the tissue, the scar, and then you just do apposition, and then that is all. The keloids, the hypertrophic scar is gone and it will never come back. If you're not comfortable with a surgery, we can still do injections. We can just do injections weekly for 8 weeks, or we can do surgery if you're comfortable. In the keloids, apart from the intralesional keloidectomy plus steroid injections, we can also have another option. We can first do intralesional injections first. We inject you first, we let it shrink, we excise it, and then we continue with the treatment, injections, weekly for 8 weeks. The other thing that I've seen work is radiotherapy. We can just do radiotherapy alone, or we can first excise the keloid and then we do radiotherapy. Depending on your surgeon's preference, they can first do radiotherapy and do the excision, or just radiotherapy alone. The thing I've seen people worry about radiotherapy is the predisposition to skin cancer. However, we don't prolong exposure. We can do 2 to 3 cycles. Some people can even go up to 5, but we don't prolong exposure. So you're most likely not end up with you won't end up with skin cancer, because we are not prolonging exposure to radiation. The other thing that I've seen work for the keloids is laser therapy. That also works. Even some studies showed it works. There's a study that I read, laser therapy also tends to work. Silicone gel can also work in the keloids, so you can also opt for the silicone gel. You can discuss with your surgeon depending on what option is better for you. You can always choose. You can always have a choice on what to choose for treatment of your keloid. Yeah, so that is what I heard about the keloids and the hypertrophic scars. Now, I want to talk about how can we avoid having keloids and hypertrophic scars in the future, because like I told you in the first video, when something happens to you, you always have to make some changes. And these changes can actually help you to make sure that you don't repeat the cycle of what happened. So when you get a keloid or hypertrophic scar, you can as well make some changes so that you don't end up in the same situation of getting a keloid or a hypertrophic scar. So let's start with the hypertrophic scars. Like I've told you, they tend to occur in infected wounds, wounds that have lost a lot of tissues, wounds that tend to undergo continuous trauma, and also wounds that are under tension. For example, those ones that are perpendicular to the Langer lines. So what can you do to make sure that you don't end up with a hypertrophic scar in the future? Number 1, avoid infecting your wound. And that calls for making sure that even if you're discharged from the hospital, make sure that your wound is closed with a sterile dressing, so that we limit the exogenous sources of infection from entering your wound. So your wound should be closed until stitches have been removed, because you can easily get infection of that wound if you leave your wound open. Just imagine getting out of the hospital, going back to the community, you're walking around the road, you have a wound on the foot or the leg, dust is entering your wound, debris, bacteria is entering your wound. So it is really, really safe for you to make sure that your wound is closed with a sterile dressing. You can buy the sterile dressings in the pharmacies. They are there. Pre-packed sterile gauze is sold in the pharmacies. You can get that gauze and then get a crepe bandage as well and then cover your wound until stitches have been removed. I always remove stitches from my patients after 14 days because I am very sure that I will not have wound dehiscence. I will not have their wounds gape. So after 14 days, at least you're safe not to have wound infection, and it is really safe for you to make sure that your wound is closed until stitches have been removed. For 2 weeks, let it be closed. The other thing that you should avoid is to prevent recurrent trauma to your wound. And that calls for making sure that you don't, for example, you formed a scab. I think that is where I went wrong. If you have watched my first video, I sustained an abrasion on my face when I fell off a speeding motorbike, and my wound healed by re-epithelialization, and I formed a scab. And I was in a haste to go back to work. So what I did, and I wanted to go back to work, but funny enough, I didn't want to go back to work with my scab on my face. So I removed my scab from my face. This is the injury I got. You cannot see my scar when you're very far, but I promise me if you get close, you can easily see it. So I didn't want to go back to work with my scab, so I removed it. And I feel like I caused some injury during that time. There was some irritation that happened. And I feel like it contributed to how my scar came out, the end product of my scar. And there's some degree of hypertrophy, by the way. Yeah, there's some degree of hypertrophy, which you cannot easily see when you're very far, but when you get close to me, you can easily see that. Yeah, so I urge you not to cause recurrent trauma to your wounds, and that calls for taking time off to make sure that you first heal before you proceed with your work, before you go back to maybe domestic chores. Because imagine you have a wound on the hand, and then you're in the sink trying to wash dishes. You're causing more trauma to that wound. And I urge you to make sure that you first give yourself time to heal so that you can have very good outcomes in that scar. The other thing that I noticed that can actually help with the scab, because remember, after 14 days, you get the stitches out, but that scab is there. What you can do is you can put Vaseline gauze. Instead of you removing the scab mechanically, you can just put Vaseline gauze, or you can just use Vaseline only. Vaseline can also work. Vaseline has a way of rehydrating, making sure that your wound is not dehydrated, and even if there is a scab, it can just get away, be dislodged with grace and without causing mechanical trauma to your wound. So I urge you to just put Vaseline. After stitch remove, after 14 days, just put Vaseline. It will prevent your wound from getting dehydrated, and also if there is a scab that has been formed, it will just be removed and dislodged with grace and with little trauma to your wound. After some time, it will just go away by itself. So that is what I wanted to share when it comes to your scab that has formed. Don't cause trauma to your wounds. Don't be in a haste to participate in house chores, participate in farm duties. Give yourself time to heal so that your wound can also heal better with better results. The other thing that I have seen that can predispose you to a hypertrophic scar is causing tension in your wound. For example, you had a cesarean section, you're a girl, you're a woman, you had a cesarean section done, and you're in a haste to continue with your daily workout routine. I understand it is very, very tempting to make sure that you stick to your routine. I am someone who is also very obsessed with being fit. But during this time of your wound healing process, make sure that you dial down your workout routine. Let it be gentle. Don't be aggressive with yourself. Just walk around. Just do walks. Don't do aggressive sit-ups. Within just a week, you're trying to do sit-ups on a cesarean section scar, cesarean section wound. When you apply tension to that wound, by the way, it's like you're trying to communicate to your body that I am falling apart. because when you apply tension, the edges are gaping. And when they are gaping, you're communicating to your body that I need to be kept together. I am falling apart. Please, please, please create more collagen so that I am kept together. That is what you're trying to communicate to your body. So I urge you to dial down your workout routines at least for the first 6 months. And then after 6 months, you just proceed with your workout routine. It's not like you're going to really, you don't need to, really. You don't need to. You just have to make sure that you stick to the light exercises, walks. Just walk around. 30 minutes is enough. 30 minutes is a day is enough for you. During this wound healing journey, just walk around 30 minutes, take a 30 minutes walk, maybe 3 times in a week. Or if you want to be aggressive with it, but also gentle to your wound, you can do it just daily, the entire week. That can also work for you. Yeah, so those 3 things can actually predispose you to the hypertrophic scars. With the surgeons, plan the incisions better most of the time. We make sure that we make the incisions parallel to the longer lines, to the lines of tension, so that you don't end up with these scars. However, those 3 things I've told you, tension, causing infection, causing recurrent trauma, can easily predispose you to the scar, to the hypertrophic scar. So make sure that you avoid those 3 things. Make sure that you avoid those 3 things: infection, causing tension in your wound, and also causing recurrent trauma to your wound. The other scar is the keloid. There's also something that you can do to make sure that you don't end up with a keloid. For example, like I've told you, the keloids occur in family. They have a genetic predisposition. So that means if your mother has a keloid, please make sure that you avoid intentional trauma to yourselves. For example, you want to have an ear piercing for aesthetics, I advise you to just abstain from that. Because you're genetically predisposed, remember, these things run in families. They have a genetic linkage, meaning your mother has a keloid. Please abstain from causing intentional trauma. Avoid piercing your nose, avoid piercing your ears. Please avoid. You also realize that the keloids can also happen on the chest, on the below the neck, on the arm. So avoid trauma to those areas. Avoid trauma to those areas. Okay? Avoid trauma to those areas. You can also make sure that you're cognizant and aware of your environment, because just a slight door knock can easily predispose you to a keloid. You can just have an overgrowth of tissue out of just a door knock. So you have to be cognizant of your environment, aware of your environment, so that you're not knocked by stationary objects, you're not knocked by moving objects. And that also calls for making sure that you look at your circle. Like I told you in the previous video, look at your circle. People that are aggressive, that can easily beat you up, just be around safe people that are protective of you, so that they don't again cause trauma to you. Because for you, you're genetically predisposed. Any slight trauma, you're going to end up with an overgrowth. And remember, they are not easily managed. These keloids are very stubborn. You can easily have a treatment option done on you and then they recur. Recurrence rate is very high. So I urge you to make sure that you limit trauma to your bodies, because you are genetically predisposed to this overgrowth. Yeah, that is what I had for you today. And I really just want you to know that I had a great time sharing my insights, thoughts, and opinions about the wound healing process, the abnormal scars, and I just want you to please continue sharing my videos, continue subscribing to my channel, continue liking, continue commenting on my videos, and I'll see you in the next video. Bye.